I will be the next speaker following Dr. Yu to talk about potential drug resistance. I want to see what is the role of deep level sequencing. And you mentioned that it picked up some loci that are missed out on the first generation sequencing. So I would expand on that. I talk about the pre-treatment potential resistance. It is an issue that we did not pay much attention to initially. Here are the framework of my presentation. The first one is the concepts, and then the severity of drug resistance. The third one is the current status of potential pre-treatment resistance, and the fourth, its potential impact on treatment outcome. Here shows the definition of HIV drug resistance. It is a genetic failure that after genetic mutation, the virus became insensitive to the ART. That means the drug suppress the growth of the virus by 50% or 90%, but it takes dozens of times of concentration compared with the baseline. However, with that level of drug concentration, the drug toxicity is also significantly higher. It is well represented with this chart. The FC value is something we look into. It is also used in differentiating the severity of drug resistance. IC50 means the drug concentrations required to suppress 50% of viral growth. It is a change of the drug concentration required to suppress half the amount of the virus. Here shows drug resistance testing. We can do it with genotyping or phenotyping. For the genotyping, it is not quite available. Recently, I had another meeting with the government officials. We talked about the new and advanced technologies for testing, and it seems that the officials feel that these assays are too advanced for widespread use. It should be used only in selected laboratories, so the access and prevalence of this type of phenotyping is limited. Another type of drug resistance testing is phenotyping, and we look into specific loci of drug resistance, and we can have the entire landscape of drug resistance from those assays. In terms of mutation, it could be primary mutation or secondary mutation. The primary mutation means that the mutations occurs to the gene loci that directly related to the enzyme of the virus. In contrast, secondary mutation is an adaptation to the primary mutation, so it further reduces the sensitivity of the virus towards the drug. They are in line with the logic of survival for any biological species. However, it is harmful for the host. There are other relevant concepts, for example, transmitted drug resistance. And if I mispronounce Dr. Jordan's name, I'm sorry. But here I will use the proper English name for the transmitted drug resistance. It is TDR. It is complicated. Therefore, in 2015, WHO no longer recommend the regular use of TDR monitoring. Instead, as Dr. Jordan showed us, we monitor drug resistance for initiators and reinitiators. That means whenever it is a type of assay for pretreatment drug resistance or existing resistance. Also, the WHO had some definition focusing on the population-wide drug resistance status. For example, according to the definition, it looked into the population above the age of 25 or specifically for acute infection. There are reasons why TDR is no longer routinely used. For example, 6 months out from initial exposure, the strain landscape might have been changed. That's because the pressure of ART. And we are not sure the conversion of the drug resistance strain into the viral strain profile in the individuals. That explains why we have patients who develop resistance 6 months after ART. That's because initially there are hidden resistance strains within the individual. So currently, we look into pre-treatment drug resistance or primary drug resistance. So we can call it PDR, pre-treatment drug resistance. It covers several scenarios. For example, transmittable drug resistance or resistance found among reinitiators. That means people who have been exposed to antiretroviral agents or PrEP. For example, the first-line regimen with EFV as the backbone. It could be a source of exposure that explains pre-treatment drug resistance. This is relevant to the pre-treatment drug resistance surveillance mentioned by Dr. Jordan. It explains why it's important that we monitor drug resistance among patients, and also it explains why we need to cover INSTI in our drug resistance program. In 2018, WHO recommended DTG as a backbone for first-line regimen. Therefore, our drug resistance program should cover INSTI. There are other relevant concepts, for example, M1A4 mutation. Within 16 to 24 months, it could be picked up by sequencing. That means when one is resistant toward EFV, then the drug resistance is present and detectable for the next 3 years. For example, you picked up a drug resistance loci today, but the patient did not initiate ART until 3 or 6 months later, then we need to do the drug resistance surveillance again, because during this 6 months defer phase, the patient may be exposed to other resistant strain. For the acquired drug resistance, it developed during ART, in particular after 3 months after initiation. And according to the WHO definition, we look into emerging resistance after 6 months of ART. But clinically, we could recognize that type of resistance with only 3 months on ART. We may discuss this difference later. It could be a result of drug-drug interaction or poor patient compliance. Therefore, we need to keep the patient with drug resistance surveillance to ensure whether there is acquired resistance. Another concept we usually use is cross-drug resistance. We call this CDR. I call it CDR, but it is cross-drug resistance. That means if the individual only receives ART when the viral load is very high, then after 6 months of treatment, the drug resistance profile may be different. There would be extra loci that the first set of drug resistance tests did not show. That means during the ART, the medications of the similar category or the same category would interact and have a complicated effect on the strain profile of the individual. Also, here shows recommendations of the frequency and the type of testing for drug resistance according to patient character. For example, whether it is a newly diagnosed but treatment naive, or someone who has been on ART but with a viral load higher than 200, or ART initiators who has not reached viral suppression, or individuals who have never been treated but with a significantly high viral load. The higher level of viral load may also be explained by the infection of some very potent viral strains. Here shows the severity of drug resistance. This concept has been adopted first, and it's been adopted for quite a while. There are also good assays and kits that we do this. Initially, we had to rely on some primitive laboratory models, but currently we have advanced kits. This is relevant to the monitoring strategy described by Dr. Jordan. So we assign score to the strains, and for the strains with lower score, they are still sensitive to the drug, but when they are high, that means they are of higher grade of resistance. That is the scoring for the phenotyping, genotyping, and now let's look at phenotyping.
So this is the definition of the phenotyping grading FC scoring. When you read the literature, you should note those scoring system. So why there is a phenomenon of cross resistance? I'd like to show you, for example, M184V. So that's for lamivudine and the STC. So it will make the two drugs highly resistant. So you can see that once the drug is once the virus is resistant to lamivudine, you can see that for ABC, the score also increased. So that means when the patient acquires M184V mutation, the resistance level to another drug like ABC will also increase. So this is the so-called cross mutation. And also you can see that the AZT will be a -8 and the D40 will be -5. So that's the good side, of lamivudine resistance. When the drug is resistant to 3TC, the virus will be more sensitive to AZT and the D4T. So that means when the virus is mutative to 3TC, the virus will still be sensitive and being more sensitive to other drugs. So that's why we can still keep the 3TC in the regimen, because the 3TC, the existence of 3TC will be a potential booster for other drugs like AZT, D40, or TDF. So that's why the whole regimen will still be useful to the wild type strains. So you can see that this is the epidemiology of the pre-treatment drug resistance and also the national status. So you can see that Professor Michael also showed this to us in his presentation. And China also reported the data. I think the Chinese data is around 3% something. So this is the situation of the pre-treatment resistance. So currently we our definition of a drug resistance is at least a low varomere, and the potential resistance is not a kind of a clinical resistance. So there may be some polymorphism points or non-polymorphism points. So according to Stanford database, the interpretation of these points are that if the patient have an isolated mutation of those points, it will not lead to clinical resistance. However, when the patient also, when the virus also have some other mutation points, the combination of the different points together will make the potential resistance to the clinical resistance. So this is the data from our hospital between 2014 and 2018 regarding the resistance. And you can see that this is the situation in Beijing. And I think that back in that moment, we didn't have a very good interpretation of the data. So this is the mutation and the resistance in Beijing. You can see that if the resistance to a certain drug is higher than 5%, it's a kind of at least a low-grade epidemic of the resistant strain. So you can see that our data is 7.6%. It's higher than the line of at least a low epidemic. And also for NNRTI, it's 4.3%. And actually, about 3.15% come from the PIs or M46. And the N46 resistance is to nafivir, which is not used anymore in China and the rest of the world. So that's why that 3% does not make any impact on the clinical practice. And also you can see the resistance to efavirenz and MBP and the ripivirine. You can see it's around 3%. And also for NFV, nafivir, it's about 1.8%, almost 2%. So this is the resistance to the different drugs. And what's the breakdown of the mutation points? We have 523 cases who present a mutation in the virus. you can see that V179 is a kind of a polymorphism point. It accounts for 55%. And you can see it accounts for 55% among all the mutations. In the pre-treatment, you can see that V179 mutation accounts for 83%. And my colleague just also reported that the gene subtyping of HIV/AIDS, you can see the CRF01AE. You can see the AE is in the MSM. It accounts for the 58%. And CRF07BC accounts for 25%. And CRF08BC accounts for 52%. So you can see that the CRF01AE and the CRF07BC, they are the main genotyping. And you can see in the CRF07 subtyping, you can see less patients have a have CD4 lower than 200. And thirdly, you can see for CRF08BC, you can see that a lot of patients in this subtype have the viral load higher than 5 log, 5 orders. So you can see this is the resistance in the BC subtype. I just said that 08BC tend to have a high rate of a high viral load, higher than 5 orders of a log. Here you can see in the potential resistance, there are a lot of non-classifiable types. And here you can see the dark column. They tend to have resistance to the NNRTI, and in the B type, they have not only resistance to NNRTI but also NRTIs. And in the others column, I just said that there is a high rate of resistance, and the viral load is high. And also in this column, the resistance to ephedrine and NVP is higher than 10%. And here you can see this is the resistance of the different subtyping of gene. And here you can see that in this subtype, the V179, it has the highest percentage among all the mutation points. So what's the impact of a potential resistance to treatment outcome based on the report of 3,300 cases? You can see 2,700 are sensitive and 290 are potentially resistant, and 36 cases actually they are not the naive cases, and there are 5 cases are the primary resistant cases and resistant to proteinase inhibitor. And among these kind of cases, in the 189 cases with some continuous or ongoing first-line ART, 34 cases had a virology failure. The failure rate is 2.4%. There is a significant difference between the two groups. So here you can see that this is the baseline characteristics. For example, baseline CD4, low CD4, and the high viral load, higher than 5 logs. They are the risk factors. You can see here, among these kind of cases, all cases have a potential failure or the potential resistance to ephedrine. And here you can see not only the difference in the failure rate for the sensitive For the sensitive group, the time to failure is 42 weeks. However, for the patient with a potential resistance, the time to failure is 30 weeks. So that means for the patients carrying potential resistant mutations, there is a high rate of failure, and also the time to failure is shorter than the patient without any potential resistant mutations. So you can see this is you can see that this is the comparison between the two groups, sensitive and the potential resistance. They have a very even, very balanced baseline characteristics. The only difference is the potential resistance or not. So that is the most important factor to lead to the virology failure. And also you can see that for the patient with a resistance, with a potential resistance, it is an independent high risk factor for failure. And when the CD4, baseline CD4 is lower than 200, the risk will be even higher. So the conclusion is that the potential resistance to NNRTI is one of the risk factor, and it is an independent risk factor to failure. And the mutation points can accumulate, and when they combine with each other, they may turn the patient into a clinical resistance case. And we should choose patients with a high resistant barrier, and we should consider the future and choose those kind of high performance regimens for the cases. Okay, this is all of my presentation. We are going to have a discussion. We have about 15 minutes for discussion.